It's the Pearce Medal Lecture, and it gives me great pleasure to have Clive Peckar, who's a long-term supporter of UKISCRS and UKISCRS, and has been a director of the Society for a long time, to give this lecture today. He's a pioneer of surgical video and has introduced the section on video of surgical techniques and complications at our annual meetings. A strong advocate of wet labs to minimize risks of surgical teaching to patients, Clive opened the Warrington UKISCRS wet lab facility in 1996, and many of us have enjoyed using that facility to teach and learn. Ladies and gentlemen, it gives me great pleasure in presenting to you this year's Pearce Medal lecturer, Mr. Clive Peckar. Clive.
Thank you, Milland. John Pearce was a true innovator, and it is a privilege and a pleasure to be asked to give this lecture. When I told Judy Pearce I'd been lucky enough to receive this honour, and I'm afraid she is unable to be here today, she said to me, "Clive, I'm delighted you are giving this lecture. You are a real maverick innovator, just like John." Well, my first exposure to ophthalmology was in the summer of 1970, when I went to see Harold Ridley at St Thomas's because I wanted to do a mini elective in Jerusalem. He suggested going to the Hadassah Hospital and said he would write to Professor Michelson there, giving me a letter of recommendation. I arrived at the Hadassah, and shortly Harold Ridley's letter arrived too. His letter said, "This is to introduce Peckar, who is a medical student here. I do not know Peckar, but I understand he is an about average student." Thus began my career in ophthalmology, and needless to say, I didn't go to the Hadassah, but decided to follow my English roots and went to the St John's Ophthalmic Hospital in Jerusalem, where I came under the enthusiastic wing of Bob Youngson, who was a colonel in the British Army in ophthalmology and came back and had a career in ophthalmology here later. He encouraged me to submit a paper for the St Thomas's Hudson Prize, and following this, Harold Ridley and John Winstanley invited me to apply for the ophthalmic house job at St Thomas's, which I did in 1972. Now, I'm afraid we don't have any photographs of that time, but I assisted Harold Ridley performing an ICCE without an implant on a 21-year-old. When I say I assisted him, actually he was assisted by his senior registrar. I can't see the laser pointer for some reason. I think it's because it's back projected. There has to be an alternative technology solution. Here we are. That's his senior registrar. That's Harold Ridley with his Graphie knife. And this is me, the very nervous house officer, hand-holding a light. Harold insisted that the light was held on the eye, it's a mains light, and I kept being admonished for not keeping the light still. My first experiences of IOLs and video as an SHO, I observed Binkhorst and Fyodorov doing Binkhorst and Fyodorov 4-loop lenses implanted by Dermot Pearce in 1973. Again, no pictures of this time, but you can see the operating theatre, and in the middle of it there were two tables in Croydon under general anaesthetic with an anaesthetist running between the two. Dermot was perched on his operating chair. Many of the operating microscopes were homemade, and one of them had a hovercraft base, so he could whiz between the two tables. And on the back wall, you can see there is a reel-to-reel black and white 1-inch videotape. I implanted a few 4-loop Binkhorst IOLs while working as a registrar in Manchester and was very keen to learn more about IOLs. I went to a UKISCRS meeting, UKISCRS having been formed in 1976 with Neil Dallas as president and John Pearce as secretary at John's home. I joined UKISCRS on the 12th of November 1981, 30 years ago, while training as an SR in Liverpool and routinely performing ICCE. Well, in 1983, the year I took up my consultant post, IOLs were gaining respectability following a lead BMA editorial. Helon was introduced into the UK and ECCE was making a comeback combined with IOL implantation. UKIS discussions on new surgical techniques were invaluable, but there were no videos of complications shown, and Kaufman's work on PMMA IOL endothelial adhesion was recognised, but there were no endothelial images shown. The Faculty of Ophthalmologists Annual Report 1983-4 stated, closed-circuit television should be provided for the scrub nurse and others to observe ophthalmic surgical procedures. Was there a need for video as well? What were the benefits of introducing routine video recording of every ophthalmic microsurgical procedure? Well, in 1984, the routine videoing of every procedure, microsurgical case, took place in Warrington. All cases had pneumatic video for learning and teaching, enabled detailed analysis, provided unique video of technique, complications, and the unusual. One Friday evening, the phone rang, which wasn't surprising. For that first year, I was working a one-in-one rotation, and it was a physician colleague of mine, a consultant at the hospital, who'd noticed some irritation and some strange sensation in his eye. I discussed it with him in some detail and learnt that he had been to Nigeria working as a physician there 6 years previous, and so the following morning, on a Saturday, we went to theatre under topical anaesthesia.
The area is grasped with the forceps, and the object, which is deep to the subconjunctival connective tissue, is held firmly, while a blunt dissection is made through the very thickened and inflamed. After what seemed like an age, the worm was withdrawn from the conjunctiva. And we can see that it is a lower. They are around 0.5 millimeter in diameter. You will see that this worm is 42 millimeters, or 1 3/4 inches in length.
I'd seen Daniel Owen Rose's presentation on YAG laser capsulotomy at the OS UK in 1982, and she'd had no complications at all, which all seemed to be too good to be true. I needed to establish the ease of use prior to purchasing, but I had no patients with PCO because we'd only just transferred over from ICCE. I rang John Pearce, who had developed a needle knife capsulotomy technique, and said I had this problem. He said, come on down to Bromsgrove with a laser, I've got some patients. So I went to Bromsgrove, we did some YAG capsulotomies, and following that we had a YAG laser installed in Warrington, the 5th one in the country. Video was needed for slit lamp documentation and laser treatment. And here you see the setup. We had to use a 3-tube camera, which is why it's so large, and pneumatic. Here you see bleeding from an early PI with pigment release, and the bleeding stopping spontaneously with pressure on the contact lens. And this is a pupil-supported 4-loop lens with a safety suture above. This had been done in another hospital nearby and sent to me because the anterior chamber was shallowing below due to this vitreous adhesion, and it was possible to focus on the adhesion with the YAG and deepen the anterior chamber.
I'll show you that again in case you missed it. There we go. Early capsulotomy. Sorry, we've jumped there. Okay, I'll move on to outpatient slip-out videoing of children. This is always difficult, keeping children still. Here you can see these cylinders attached to the upper lashes of this 5-year-old. And you can see the pediculosis pubis, or crab lice for the uninitiated, swinging from lash to lash quite happily. This young chappie was not happy when I saw him. He's 8 years old and he presented with a red skin rash, very sore red eyes, no obvious cause and no obvious history. Under high magnification of his cornea, it was possible to find these tiny linear structures embedded in his cornea. Some of them were almost protruding, others were in the middle, and some were entering the anterior chamber. Question was, where did they come from, and why did they set up so much irritation? This is his pet tarantula, and it's the hairs from the tarantula. Well, this can happen in two ways. One, if you frighten the spider, it can eject the hairs at high speed, which can embed in you, or you can pick them up on your fingers and self-inoculate them. Interestingly, following him for a couple of weeks on high doses of topical steroid, KPs were seen to appear on those lashes that entered the anterior chamber, gradually digesting them until the eyes settled down completely. Kaufman and others in 1976 to 80, we haven't had any surgery. Are you all right? No, you'll find out. Noted that bullous keratopathy followed contact between PMMA IOLs and the endothelium. I had seen endothelial specular microscopy using photographs performed by Hung Cheng whilst in Oxford. Only small areas of cells could be seen on photographs, and it was not possible to look at large areas. Clinical decisions were delayed pending the developing and printing of the photographs. Possible damage from YAG laser was a concern. Therefore, wide-field endothelial examination with video was investigated. Endovids, term I coined for endothelial specular microscopy and quantification using video. The Pro-Kessler specular microscope was the first one tried, which was contact wide field and produced posterior corneal rings, because of the contact nature, which act as a fingerprint for subsequent area relocation. Endothelial endovid quantification was looked at both manually, automated and semi-automated.
And sit back, please. Assess the approximate cell density per square millimetre. An acetate grid is placed onto the monitor. 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22.
It's quite a crude method of quantification. The squares are 0.1 of a millimetre across, and if you include the cells on two sides and ignore them on the other two sides, you get a very good average cell count just by multiplying the number by 100. So 22 would be 2,200. That's a very useful method we used for some years afterwards,
But I did go ahead and look at boundary quantification, which is used by a lot of semi-automated methods now. One method of boundary quantification is to draw around the layer of cells you see most clearly, which is a little bit laborious, and once you've finished drawing around them, you use fairly simple algorithms to calculate the total surface area, and if you include the number of cells in the middle, you then have the average cell density. So we then mark all the cells, and you get the cell density by calculating the area and dividing it by the number of cells. So it seemed that automated would be much better and much quicker. Different algorithms are applied in order to change the grayscale image into a true black and white image. And as you see, it works quite well. As you work through these, you can find most, but not all of the cell boundaries, because you get some cell boundaries that are missed, and some in which parts of the nuclear fragments look as though they're cell boundaries. So you then have to edit the whole thing by hand to come up with an absolute count. And that's happened with even some of the most latest systems. So most of us have ended up with a semi-automated method. The Procastle had fixed magnification, and a lower magnification was needed to search endothelium for focal pathology. Comparison with Procastle and Conan, with different cones fitted with black and white low-light video tube cameras. This was shown at joint meetings of UKISCRS and RSM in 1985 and the US-UK in 86. My next task was to persuade Conan to build a zoom endothelial microscope to enable the scanning of large areas of endothelium for focal pathology, for example, YAG laser damage. Only 2 were ever made. This is the machine. Here we're adjusting the zoom and the position. You operate from the side, so you get a clear view of where you are on the cornea, and you can map out the cornea looking for focal pathology. And a little video printer there enabled you to print off the slides you wanted to keep in the records, and whatever magnification you worked at, you had a guide on it showing you the 0.1 millimeter square area. This was an early case that was sent to me when we were investigating the endothelium. A patient who had had RK just over a year previously, and the surgeon wanted to know if there was any evidence of endothelial damage. So by zooming in and out in the areas of the RK scars, we're able to look qualitatively as well as quantitatively at the corneal endothelium and establish that in fact it was normal in RK. This is an early case showing corneal polymegathism. Polymegathism is probably the most important reason for doing a specular microscopy, because it allows you to make sure the endothelial cell population is normal in patients who have otherwise normal looking cornea. This patient has normal looking endothelium when you examine the central zone and most of the areas. However, when you zoom out and go travelling around, you find out there's a large focal area of cornea guttata. And when you're trying to work out risks for patients of corneal decompensation, you need to have an idea not just on the size of the existing cells, but the extents and confluence of the guttata. Here was a patient with a thick brown iris having a YAG iridotomy. Many people now would pre-treat this with argon, but this is treated just with YAG. And you can see it needs quite a few blasts of the laser in order to go through there. You see the pigment released, nice PI. And when we scan with the laser, with the endothelial specular microscope, we can see a focal area of YAG laser damage. Fortunately, it had no effect from this. So the conclusions were that Zoom Endovid found to be the best for scanning large areas of endothelium and relocation using posterior corneal rings. Primary polymegathism was seen in 1 or 2 new routine cataract patients per year and may lead to decompensation. and some of these patients were referred by others. They'd had so-called routine cataracts, and the surgeon had had an endothelial surprise the next day. So why do preoperative specular microscopy? To identify any specific risks to the cornea and explain the risks to the patient, for example, giving informed consent, to prevent the surgeon having post-operative corneal decompensation surprises, and in those cases with compromised endothelium, to consider if surgery is necessary at this time. I will often have an elderly patient who's managing fairly well with 6/9 cataract, perhaps been referred in, we do this cataract, got quite considerable endothelial damage. Yes, if they've got corneal guttata, you can identify this on the slit lamp. But if they only have polymegathism, you won't know until after you've done that procedure. Endothelial quantification by optometrists was started in 1986, and the Conan-Robo non-contact specular microscope in 1995. Routine non-contact qualitative screening by nurses for all cataract patients in Warrington from 2008. The screeners and other people involved in the cataract pathway had a guide written for them, showing normal endothelial cell populations, showing with a normal count at birth around 3,000, and expecting a count at around the age of 70 of 2,000. The cornea decompensates by 400, and the minimum count to proceed with surgery was set at 1,500, providing there were no other abnormal findings. Here's a 40-year-old with a normal right eye, and a count of 2,700, and post-traumatic left eye with post-traumatic polymegathism, 1,757. No reason not to carry out routine cataract surgery on that patient. Here's a patient with early guttata, quite a respectable cell count. I would examine the cornea in more detail in other areas to see how widespread it was, and this patient had routine cataract surgery, no problems. Here's a patient with polymegathism. You can see when you look at the size of the cells compared to the grid on the side that they are larger. In other words, the cell count is somewhere between 700 and 800 perhaps. And these cases are all at risk. Here was one preoperative cell endovid and cornea decompensated afterwards, and here's another one. Can you do anything about it? Yes. Any count of 1,500 or better was taken and processed normally, and if areas of cells couldn't be seen or the picture was blurred, multiple images were taken. Should every intraocular surgery patient have endothelial screening? Is it worth it? Does it influence management? Many surgeons say, I take care with every case. What about cases of previous trauma? You have no idea what you're dealing with if you don't have an endothelial cell count. If you get a normal count, that's reassuring, and if you've got guttata in a count, you can give the patient some idea of the likelihood of decompensation. The same happens with polymegathism. So informed consent, is it cost effective? Well, I couldn't possibly comment there. But what if it was your eye? Would you want endothelial examination? One of my very good friends came to me for cataract surgery. Unfortunately, I did specular microscopy, and she had polymegathism, and I was able to take extra care in the surgery, really prolonged soft shell technique, and very, very low power phaco, and no problems with the eye at all. Please remember what Norman Jaffe said. He who doesn't count, doesn't count. Well, UKISCRS in Torbay 1988, we had a symposium on current techniques of IOL surgery. This was important because it introduced video recorded surgical techniques and complications as a regular feature at UKISCRS annual meetings, and it was a watershed. As at this meeting we had intracapsular cataract extraction, extracapsular cataract extraction, which was the normal at the time, and the beginning of phaco. Here is Michael Absalom. I hope we have sound.
You see a great reception.
Sound louder, please.
You see a graphy section. Although we'll see quite a lot of bending even with expression later. Cryo extraction. Of the whole lens. Here, Aruga's forceps are being used to remove the lens. Using anterior chamber lens with viscoelastic under air. Myself. 2 plain diamond incision. Usually 2 incisions prior to capsulorhexis. In this case, the incisions don't quite meet, but to make a further incision and then remove the capsule. 7mm one-piece lens, envelope technique into the bag. Not. Two plain diamond incision. They often deliver the nucleus if one is patient.
This is very nice because with just superior pressure, nucleus is coming out, the cornea isn't bending at all.
However, this does not always work. In this case, the nucleus remains well in place and inferior pressure is required. Together with direct pressure over the inferior cornea. You see a large globular cataract. What? Here a Hirschsprung spatula is used to guide.
This was Eric Arnott's encircling lens, which was very good at providing concentration.
Loop. IOL.
And the first
sculpturing.
First case of phaco to be shown at UKISCRS.
As an alternative to nucleus expression.
But you'll see we had no divide and conquer technique at this time. There was the actual phaco technique relied on using fairly soft cataracts and being able to use a lot of aspiration in order to pull nuclear particles forward.
nucleus being moved prior to aspiration. The remaining cortex is removed with infusion aspiration.
So it was relatively easy to obtain nice case videos, but problems obtaining videos of complications from colleagues. I remember I was sitting next to Eric Arnott on a coach going to an IIIC meeting sometime later, and I asked him, please, can you let me have some videos of how you handle complications? He said, what sort of complications? Capsular rupture, dehiscence. Oh, he thought for a while, and then he said to me, I don't see capsular tears. Perhaps it's due to geographical variation. Maybe the capsules in London are thicker than in Warrington. Well, unfortunately, up in Warrington, I did see capsular tears, and I shared them with the audience.
On the subject of vitreous presentation, I want to show you in a minute a hole appearing here spontaneously. There you are. I wasn't doing anything. It was an act of God.
Clive, when you showed that spontaneous posterior capsule tear, it's a question of how it did arise, and I was wondering, really, when Pearce was saying that anterior capsulotomy doesn't, in fact, extend beyond the equator, that was an instance where it did, perhaps. Otherwise, how could that tear have occurred there?
It wasn't there when you started aspirating, was it? It was there after.
No, I think it was very... Yeah, well, you didn't see it until it extended, and then it extended more. But there must have been something from which it started.
But it looked to me as if there was some degree of pressure, and the vitreous must have somehow bounced.
Clive was actually inside the eye at the time, and he was pushing, but I think we've all seen, and I confirm Clive's belief, we've seen a dehiscence appear, obviously in the capsule rather than the sonule, when you're not actually in the eye, when the instrument's out of the eye. And indeed, when you're getting the lens for implantation, ping, it will suddenly go. So there must be weaknesses that do give way.
I really showed that case with those comments to be a bit of a devil's advocate. I always maintain that every case should be videoed, and then if a complication develops by studying the video, you can, in virtually every case, see the cause of the problem, and that these acts of God aren't acts of God at all, but are always acts of the surgeon.
The surgeon sees less than the video, I'm sure.
And of course, there were a number of contributions at that meeting from John Pearce.
Could I just comment about the question of if your posterior capsule goes, and you've done the intercapsular technique? I think that a sheets glide is something one should always have available, because once you've cleaned up, then if you put that sheets glide gently into the bag, you know it's there, and it gives you a sense of security, because you can feel with the sheets glide if there's any hole inferiorly, or you can move it in the oblique, and then you can find the area of the capsular bag where you can just put your lens either behind the bag. I usually put it behind the sheets glide rather than in front of it, or I even put two sheets glides in.
Well, are we ready for video? For phaco? Charles Corey?
Can I ask the panel what they feel about making a very much smaller section and going over to phaco?
The decision you have to make is, do you want a small incision or a large implant? And the current feeling is, I believe, that a large implant will perform best of all for that patient in the hereafter. Point is that smaller lenses tend to be a compromise, and decentration is more of a problem, as well as their manipulation. So delightful as phaco technique is, the appropriate lens in my book doesn't yet exist for it, and therefore there's little point in removing the nucleus by that method when it can come out quite easily by simpler methods.
Should you video every case? The use of digital recording media makes it easy to record and discard repetition. But do use good quality analog or digital camera with preferably a camera XY side tube adapter. Yes, you should video every case to allow you to do informal teaching as well as formal lecturing, for self-learning and complications and the unusual. You don't know when you're going to have a complication. As surgeons moved from ECC to phaco, there was an increased incidence of capsular rupture and drop nuclei. In 1992, the day before our main annual meeting, we had a phaco wet lab in Warrington, followed by live surgery to show different surgeons' phaco technique. This combination of teaching allowed trainee phaco surgeons an opportunity to practice on pig's eyes rather than on patients, and allowed them to see the different approaches to phaco by different surgeons. It was universally agreed the wet lab provided the best method available for trainee surgeons to avoid practice on patients. While all agreed that live surgery demonstrated surgeons' particular surgical approach, members of the society were divided as to whether live surgery was really fair to both the surgeon and the patient. During the early 90s, although the need for regional national wet lab training was recognised, no permanent trade-independent facilities existed. There was no funding for setting up surgical simulation laboratories in ophthalmology, although funding was available in other disciplines, for example, laparoscopic cholecystectomy. The cost of setting up a 9-station phaco wet lab with totally new equipment was around £700,000. However, with donated equipment, the cost was considerably less. A combined microsurgical training wet lab and live surgery facility that could be used by UKISCRS members was proposed informally during the ESCRS meeting in Lisbon and the UKIS meeting in Chichester, both in 1994. The overriding principle was that all surgeons should have the opportunity of practicing techniques in a simulated situation prior to operating on patients. Warrington was suggested a suitable site because its central geographical location, previous experience in organising live surgery and wet labs in association with annual meetings of UKISCRS. Optic UK had requested a semi-permanent or permanent site for annual meetings, and Chester was proposed as a possible venue to hold the national meetings. Relocation of the Department of Ophthalmic Surgery into its new ophthalmic centre in Kendrick Wing provided some additional space on the first floor, which was not suitable for patients. This was the wet lab. You'll see there's a central hub connected to a 9-station wet lab, a seminar room, ophthalmic theatres, and also to the outpatients where we could accommodate up to 70 people. There's also eye preparation instrument storage facility. The 9 stations were all collected together with video and audio. In the eye preparation room, here's an eye being prepared, being deepithelialized with a pellicuris brush, and this is the wet lab. 1996, the first Warrington wet lab and live surgery session with the encouragement of UKISCRS Council and the support of the ophthalmic trade, together with Optic UK, the UK's first permanent multi-station wet lab with direct video links to the lecture room and operating theatre was established. Howard Fine was the surgeon from Oregon who carried out phaco under topical, and there was a wet lab of LASIK microkeratomes. Here we are at that first meeting. You can see I'm looking extremely pleased with myself. Howard Fine standing behind me, extremely exhausted, having stepped off the plane from Oregon, and behind him Emmanuel Rosen, Paddy Condon and Sherez Dyer. Next problem was how to learn Schlemm's canal surgery. Schlemm's canal, we all knew where it was. This is Norman Ashton's neoprene cast from 1952, showing the shape of the canal and its connection with other vessels. 1956, Dwight Theobald and Kirk had pointed out that some cases of open-angle glaucoma were due to obstruction of the scleral collectors, and in 1958, Grant had demonstrated 75% of the resistance to aqueous outflow was located in the trabecular meshwork. In 1960, Redmond Smith introduced the concept of trabeculotomy. However, in his paper in 1960, he agreed with Marmonet that goniotomy in practice is not quite the same as goniotomy in theory. He went ahead to do some cadaver eye experiments where he made cuts into Schlemm's canal at 12, 2 and 4, passing a nylon suture between them and pulling it tight, causing a traumatic trabeculotomy. He also did this in one patient having an eye enucleated for melanoma. But nowhere in the literature is anything about any work on patients or any follow-up, and one assumes that his work led him to believe this would lead to scarring, which indeed Robert Stegman's work showed later. In 1990, Kozlov et al. Developed the technique of deep sclerectomy using Decimase membrane and collagen implant to produce an indirect fistula under the conjunctiva. And in 1999, Stegman published his paper, Viscocanalostomy in Black African Patients. In the adjacent paper in the American Journal of Cataract and Refractive Surgery, Mahmood published comparison of deep sclerectomy and collagen implant with trabeculectomy. And as both were considered as non-penetrating surgery, this led to some confusion. So on the subject of non-penetration, there are two types of non-penetrating operations. Non-penetration into the anterior chamber combined with drainage through the outer sclera beneath the conjunctiva, bleb-dependent surgery, for example deep sclerectomy, and non-penetration or minimal penetration into the anterior chamber combined with non-penetration through the outer sclera with drainage into Schlemm's canal. Schlemm's canal surgery or bleb-independent surgery, viscocanalostomy or canaloplasty. In 1995, I'd seen Robert Stegman presenting videos of his procedure for treating open-angle glaucoma by re-establishing drainage through Schlemm's canal. I felt there had to be a better procedure than trabeculectomy, but I did not understand the procedure. I did not know whether it was applicable to my patients. I did not know whether I'd be able to perform this procedure. It took me 2 years to persuade him to visit Warrington Hospital to run a 2-day training course. However, on the 22nd of May 1997, training commenced with a wet lab, theoretical videos, previous surgical cases, live surgery in the afternoon and morning, followed by a wet lab on the second day. Here you see the group of us assembled then. In the back row, Ian Grierson, Jack Kearney, Sheraz Dar, Norbert Kerber from Cologne and Patty Condon. And in the front row, Peter Wishart, Robert Stegman and myself. All of us looking younger than we do now. Interestingly, I was unable to perform the dissection on the first day, but after 2 days of teaching and watching live surgery in detail, I was able to carry out the dissection in the wet lab the following day. 4 weeks later, I carried out my first viscocanalostomy procedure and was totally convinced of the value of combining live surgery from an experienced surgeon with theoretical videos and wet lab practice. This is the flaps as used in viscocanalostomy or canaloplasty, an outer sclerectomy and an inner flap which is removed to create an intrascleral lake and a desmetotrabecular membrane through which aqueous can be seen permeating. So viscocanalostomy started in 1997, but it has two drawbacks. Schlemm's canal and the ostia must be open. And viscocanalostomy has a 3 to 5% failure rate in Caucasians and 11% in Africans due to ostia with or without late fibrosis. Transosteal stents are first carried out in 1999, canaloplasty with a tension suture in 2005, and canaloplasty with intracanalicular stents, the Stegman canal expander, in 2010. Here you see the stents that were put in 1999, and these videos are taken 10 years later. There's no fibrosis in the canal. The stents are quite clear. The pigmentation you see is on the overlying trabecular meshwork, and the intraocular pressure remains at 15, having been 40 millimeters prior to surgery, both without treatment. That's a gonioscopic view of the viscocanalostomy window there. My results, together with Norbert Kerber's results on canaloplasty compared with viscocanalostomy, were published in 2008. We deliberately only included cases of canaloplasty viscocanalostomy alone, because adding phaco to any glaucoma procedure confounds the results. And it's very important, if you want to know if your Schlemm's canal surgery is working, that you look at cases where you're not carrying out phaco concurrently. Our results were good, 25 to 16 in the visco, 27 to 14 in the canaloplasty, meds down from 2.5 to 0.4, 2.6 to 0.2, and changing the scatter plot for canaloplasty showed an improvement in blue, and the success rate, really looking at the figures, equal or less than 17, with an 87% for canaloplasty and 68 for visco, a bit less on the without medication, 83 and 42. So this was my first canaloplasty case, a standard viscocanalostomy dissection, and the microcatheter is inserted into the ostia. The microcatheter carries a fibre optic bundle with a helium neon laser, so you can track the progress of the catheter through the canal and make sure it's in the canal and not going into a collector channel or suprachoroidal. At the same time, there's a lumen in the catheter, which allows you to inject a high viscosity sodium hyaluronate, and there is a stiffening wire as well. And every 2 clock hours, half a microliter of Helon GV was injected. In this particular case, it had phaco combined with the surgery. Once the canal is dilated and the catheter has passed 360 degrees, a tenoproline tension suture is placed on the end of the catheter. I leave the suture double because it allows a backup suture if it should snap or if the tension on the first suture isn't sufficient. But one length of suture is perfectly satisfactory. The catheter is gently removed, and then the 2 sutures, or one if you only have one, are tied under tension. This particular case, which was my first case, isn't quite as tight as I would like it, but you can see there's a concave window and you can see aqueous permeating freely through the window. It's then important to close the flap really tight. You do not want to bleb, you want all the aqueous to be diverted into Schlemm's canal. This shows ultrasound, and you can just about make out in this area here Schlemm's canal preoperatively and Schlemm's canal postoperatively. This is the ampulla between the canal and the edge of the lake, showing the double tension suture here and the Descemet's window. Collector channel microangiography can also be carried out, also known as channelography, using transcatheter dyes. Here I'm showing trypan blue. You can see the flashing laser in the background, and those vessels, which are collector channels, showing up in blue, while the ciliary veins are in red. Next stage was to introduce stents throughout half of Schlemm's canal. This is the Stegman canal expander. You can see it on its carrier. The carrier is a 6-0 proline suture, which carries the canal expander, which looks like a snake's skeleton having ribs and a flexible spine. This is 9 millimeters long. Here you see it the carrier being fed into the end of the catheter to guide the first side straight into the canal. And this allows you to, by watching the laser flashing, to just confirm you are absolutely in the canal at this stage. And once you have pulled the catheter out and fed the implant in, the stent, you can remove the carrier. Watch the blood following as we remove the carrier, blood coming out of the canal. and then we remove the catheter, and the other side is fed straight in along the line that the catheter previously occupied in order to provide stenting of the canal the other side. And this gives you stenting all the way superiorly from 3 o'clock to 9 o'clock. And here you see the gonioscopic view 6 months later, the stent in the canal. There's no reaction around it whatsoever. There's overlapping in the lake with the other stent. So new surgical techniques are becoming available to gain access to Schlemm's canal and hold Schlemm's canal open. Only time will tell how Schlemm's canal surgery will develop. I'm confident after 14 years' experience that Schlemm's canal surgery will continue to develop, and you should consider adding it to your armamentarium for the management of open-angle glaucoma. International interest in Schlemm's canal surgery is growing. I've just been training at Bern University in Switzerland and Wroclaw University. If Schlemm's canal surgery is so good, why is there such a poor uptake in the UK? On 6th of December 2009 at the UKISCRS meeting in Hong Kong, I asked, why is no one at Moorfields doing Schlemm's canal surgery? Peckar replied to me, we were shown visceral canalotomy by Philip Sordine. It is very challenging surgery. Well, back to wet lab attendances. We set up Mersey Regional Teaching, a 10-module teaching programme for all SPRs was introduced in September 1997. 79 modules were run between September 1997 and September 2011, and teaching carried out by consultants from different hospitals throughout Mersey region. This shows the courses from when we started at the end of 1996, reaching a maximum of 25 courses a year in 2000, but declining from 2003 onwards. There's becoming less and less interest for wet lab training, and why? Now, 2003 was when the RCO opened their wet lab, and we'll talk about that again later. So what have our total attendances been? We've had 2,953 attendances, 410 consultants, 2,256 trainees and staff grade attendances, 102 overseas doctors, 90 theatre nurse assistants, 57 trade, 28 vets, 10 others. And that included the RCO courses up until 2003. In 1998, I was invited by the ESCOS Programme Committee to reorganise surgical skills training at their meetings from 1999. This shows the rise in courses from before I started, which was 1995 to 1999, when we reorganised the course structure. And you can see a steady running of between 50 and almost 70 courses per year, with no deterioration. If we look at the participants, a total of 6,225 participants, again with the greatest number in 2011. This is one of the wet labs, teaching in a canaloplasty wet lab in Vienna last month. And interestingly, when we look at the wet lab participants, there were 437 participants in Vienna from 62 countries in the wet lab. The UK had the biggest slice of the cake with only 11%, while all the others were less. So what is the future of wet labs? Virtual reality simulators may help to develop many of the skills surgeons require. However, they do not impart the same feel as real instruments on real tissue. Is there still a place for UK regional wet labs? Should funding be supported by the deaneries? So far, we've been unable to obtain this. Or should it be individual study leave only? Or should it just be carried out at society annual meetings like we're doing here at UKISCRS? Or at one national centre, for example, the Royal College? Well, the Royal College opened their skills centre in 2002, 6 years after opening the wet lab in Warrington. I was invited to sit on the microsurgical skills subcommittee to help organise courses and plan the RCO's own wet lab. On October 3rd, 2003, the RCO Skills Centre was opened by their patron, His Royal Highness Prince Andrew, Duke of York. 52 guests attended and who were invited. So Prince Andrew worked his way down the line of guests, right until he got to the very last guest, who happened to be myself. And he asked me, sort of, what are you doing here? And I said, I'm here because of my experience running wet labs. We set up a 9-station wet lab in Warrington 6 years ago. He looked at me and said 2 words. Why Warrington? Thank you.
Clive, thank you for that wonderful lecture. Your love for learning and teaching using technology was very evident in that, and I congratulate you on your pioneering work. It gives me great pleasure to present to you the Pearce Medal